Uh, Respected chairpersons, my dear friends, a very good afternoon to all of you. Before I start my lecture, I would like to express my heartfelt congratulations to Dr. Khanna for his continuous and ongoing efforts to maintain the standards of peripheral vascular intervention and endovascular interventions in our country. And once again, express my heartfelt thanks for giving me this opportunity to interact with you all regarding another important aspect dealing with renal arteries, which are not stenosed, but how to alter the renal sympathetic innervations by form of RF energy and various other new procedures which are coming up, and how could this help in these patients of hypertension. I thank Dr. Khanna for giving this opportunity. We already started doing such procedures before the advent of Medtronic RDN catheter. So he titled it as renal sympathetic denervation indigenous methods. As we all know, hypertension is the leading risk factor which leads to a lot of complications, which is very high in the list compared to diabetes, tobacco, and many others. And it's roughly, even in Indian population, it's supposed to affect about 32% of males and females in our country. And with ongoing lifestyle changes, increasing obesity, and then high alcohol and fat consumptions, and it is on the rise further. And why all of you are very much interested for this is, you all know hypertension can cause havoc in all the organs of the body, be it the kidney, brain, heart, and many other areas. So one other good thing which all of us know already is we have data coming up with SHAP trial showing that with appropriately treated patients, for every 1 month's treatment, life can increase by 1 day if properly treated with this antihypertensive therapy and pressure is well controlled. But what is very astonishing and not very liking for all of us is that in spite of using 3 or more drugs, even in the ALAHAD subgroup of patients who have more than 33,000 population, again only about 60% of these individuals have optimal control of pressure to the target values. So can hypertension be treated by any other methods by intervention without just by drugs? So we all know sympathetic nerves carry a significant role in etiopathogenesis of hypertension. So renal artery again allows us to enter into an area to alter the sympathetic nervous system. The renal artery is again has innervated by sympathetic nerve endings coming. When you see the histopathological section in the adventitia of the renal artery, so you have renal nerves innervating the renal arteries. We have data way back in since 1950s, late 60s, that thoracolumbar sympatherectomy produced significant reductions in blood pressure and also decreased mortality. But these procedures could never become popular because it has its own problems, surgical techniques, and it had produced a lot of other side effects. But can this surgical procedure be performed in less invasive way, performing using these catheters? That's the innovative idea with which this new device is made. Then this Medtronic RDN catheter, which is made basically to deliver RF energy to this. And the mechanism, the basic theory behind it is not to produce the circumferential lesions all around, because at the same point, if all the lesions are produced, there could be chance of restenosis happening in the renal blood vessel. So what is the principle behind is to provide series of RF energy delivery at various levels, like 6 o'clock, 9 o'clock, 3 o'clock, and in a phasic manner from distal to proximal. I'll touch upon that, how it is done in subsequent slides. So that's how alter the sympathetic denervation of these patients. So this is the pictures of one of the few of these patients. Initially, the lower end is done, then different positions it is being tackled. And when it was studied in animals, there were again significantly the nerve endings could be ablated. And then this went on to study of the Simplicity study, the Simplicity-1, which was initially a proof of concept study, took patients who were more than 160 mm blood pressure in spite of 3 antihypertensive drugs with normal renal function. And they also excluded secondary causes of hypertension and diabetes patients also because of initial proof of concept. Then what was very encouraging was there was no vascular complications, no worsening of renal functions. no orthostatic electrolyte disturbances, which were predicted that it could happen when you knock off sympathetic nervous system. So it proved that the procedure could be done safely. And then what was also very encouraging is 89% of these patients had a significant fall in blood pressures to the extent of about 20 mm systolic and 10 mm diastolic. And this fall in pressures continued for a year and further improved in the second year too. That with the encouraging data of Simplicity 1, they went on to study with Simplicity 2, which was again basically a randomized study to two arms. One is a control group in which denervation was not done, other in which denervation is done. And in these patients, baseline characteristics in both the groups were same. Some of them were even diabetes and having hypercholesterolemia. Then all of these patients were already on 3 to 4 drugs, and the blood pressures were not controlled. And after the procedure, again, it proved that procedure could be done safely with no major adverse effects, no damages to kidney, but for some femoral pseudoarterial aneurysm production, which was again treated. Then BP reduction, again, would be noted very encouraging. And then safety of this further established by, again, follow-up renal angiographic studies by MRA and CT in these patients, showing that there is no significant renal artery stenosis produced in these patients, and renal functions were preserved well. And then the Simplicity 2, the systolic blood pressures came down by 20 and diastolic came down by 12. So that is a very encouraging thing. They also went on to study how it was producing the effect. The norepinephrine, kidney norepinephrine levels and total norepinephrine levels significantly decreased. And when they went on to study, not only the blood pressures have decreased, the muscle skeletal nerve stimulation activity is also significantly decreased, showing that the sympathetic denervation was happening significantly better. So, do we need any specialized catheters, or the routine RF energy delivery catheters could be good enough? Probably, principle-wise, if you use it, probably saline-irrigated tip catheters could be doing this job better because they wouldn't produce charring at the tip, but again produce actually the lesions distal extent, not at the immediate contact point. So whenever the irrigated RF ablation histology was studied, the endothelium was preserved, but the point where we wanted, where the adventitious nerves were innervated, were getting ablated. Then this is a case example of a 46-year-old gentleman with severe hypertension to the extent of 200 per 100, and after catheter denervation, renal denervation, then produced significant fall in pressures to 148 by 96. When the three-dimensional reconstructed studies, the lesions were produced in that way in various directions, not in the concentric form at one point. Then they also studied again the renin, aldosterone, metanephrine, normetanephrine levels pre and post, which show significant fall after the procedure. Then there are still some unanswered questions and doubts lingering in all our minds. Then whether this could be having multiple mechanisms of action, how is it helping in these patients? And then can sympathetic reinnervation, can it occur again on follow-up? And could there be any about long-term negative effects on the vasculature? Then some of these could be also placebo effect. That's the criticism which came because some of these baroreceptor studies, in spite of being on or off, there was significantly some fall in the blood pressure which happened in some of these studies. Could it be that? So we need more data, more proof of efficacy concept for this. Then at CARE, we thought we were confident with this procedure, probably it could be working. And in other centers, again, Simplicity 3 and Relief are being studied, where angiograms was done in both the groups. One was sham ablation, other was rear ablation was done, and the results are yet to come out. And we at our hospital wanted to do it, and then we tested about 10 patients, and 2 were excluded because one patient's pressure was controlled, other patient, the renal artery was very tortuous. And the 8 patients, the procedure was done successfully with no procedural complications. And what we noticed, unlike the Simplicity subgroup of patients, is blood pressures came down significantly immediately after the procedure. Maybe a little more energy is being delivered when you are using this already established RF catheters compared to those which is delivered by RD and Medtronic catheter. And one patient, on a 6 months follow-up, again, blood pressure significantly increased. As to know our method, basically we use right femoral artery, 6 French right renal guide, Then we sedate these patients with midazolam and fentanyl. This procedure does cause some pain, so it needs to be adequate sedation to patient and pain relief. And the regular RF delivery catheters, which are 5 French or 6 French, are used with a regular RF generator. This is a pulse generator, RF generator, which is used. This is standard, and many EP colleagues would already know this. For the benefit of some fellows and others who are not with ET, I would just briefly explain this. This actually, I took up this slide from the recent conference which we had last year, Advanced Cardiovascular Solutions, in which we performed this procedure live. And Dr. Khanna initially was telling you could perform live, but because of some communication problem, we're not doing live. But I thought I'd just briefly explain you this. This basically has the values which you see here. The wattage can be adjusted. Generally, we keep a wattage about 10 to 15 here. And then the temperatures can be adjusted here. This is the time duration in which the energy to be delivered. And this is what is the resistance which you get it when you see. You need to monitor this resistance when you're delivering the energy. If the resistance falls down significantly, that means that significant charring is happening and you need to stop delivering energy. Generally, we give 10 to 15 watt of energy for about 120 seconds and then monitoring the resistance here. All this is inbuilt in Medtronic Ardian system. I went on for hands-on training abroad for Ardian thing, where that catheter is that system which is done is very user-friendly. All these parameters are inbuilt and checked, so there is less chance of producing complication with that. Whereas with our established systems, old RF generators which are used for cardiac ablations you need to monitor all these parameters ourselves, and you need to be a little more careful. And these catheters are also relatively more stiffer compared to the Ardian catheter, which is 4 French and which is more thinner and less likely to produce complication. This is actually a picture in one of our patients. This is a regular RF energy delivery which is happening there. Sometimes if the renal artery, one of the patients is very tortuous, initially phase we didn't want to be very aggressive, but now we know when we are doing stenting, such things could be taken abroad and then put a guide catheter, then thread it later. But in the initial phase, we didn't do that procedure in that patient. And about 8 patients are being done, and then 6 patients beta is projected here. And basically, patients' age group varied from 24 to 62. And all these patients, in spite of 3 to 5 drugs, had very high blood pressure values. What we noticed, unlike the simplicity patients, is a significant fall in pressures on table. And then in one patient, what I mentioned, again, pressure rose up after 6 months. This is again pictorial representation, more graphic forms, higher pressures, very encouragingly coming down after the procedure and persisting to stay in most of the patients normal. We sent this for publication from our hospital. All these efforts were also possible because very close cooperation from the nephrology colleagues and able referral pattern. So that's about renal denervation in control of hypertension. But we also see the potential therapy expansion opportunities of these procedures which could happen in various other things. We know that sympathetic system and renin-angiotensin system plays important role in hypertrophy, arrhythmia, ischemia, and heart failure. And there could be more potential roles coming up even for end-stage heart disease dialysis patients. And there is some data coming up with this. Not going into details for the sake of time. And we could also find it very useful in congestive heart failure patients. Now we are following up these patients with studying their LV function and BNP values also. There could be significant beneficial role of this in future. We could find more and more studies coming up with that. And the diabetes, we have some data with renal sympathetic denervation showing that it improves insulin sensitivity and leads to better glucose control. And this could be also another potential therapy role for it. Arrhythmias, ventricular tachycardias, there are already some papers presented with this, that post-ICD, the electrical storms are significantly less after this therapy. We also know that atrial fibrillation is another very important thing associated with hypertension. There are some studies planned with AF ablation alone, with AF ablation plus renal denervation. The results are yet to come. There's also some encouraging data coming up with sleep apnea and other things. So some of the technology advances which could happen is you could deliver the therapy in a better way with the ultrasound catheter or with a novel ablation approach and procedures like a balloon which inflates guanethidine all around which will lead to again sympathetic denervation. And that's newer procedures which are more safer could become the better ways to do this therapy. So final thoughts before I close, ladies and gentlemen. The catheter artery, renal artery denervation can treat refractory hypertension, but we need additional data coming up to prove its efficacy in long-term and larger subgroup of patients. And fundamentally, it could also lead to a novel approach of modulating of the sympathetic nervous system in the body, and then it could lead to various benefits for the body where the sympathetic system could be overdriven. And before I conclude, I would like to bring your notice the Advanced Cardiovascular Solutions India Conference, which we do in association with TCT. Dr. Martin Leon will be coming again this year. We have live transmissions coming up from various centers across the country. We are thankful to Dr. Khanna for also agreeing to participate in this meeting for a live demonstration. And I request all of you to join us there in August 3rd, 4th, and 5th. And August 2nd, we have an exclusive workshop on renal denervation, dealing with various approaches of renal denervation therapy. Thank you very much for your patient hearing.
Thank you, Dr. Srinivas. I have a couple of queries and clarifications. What did you say the range of fall of blood pressure was? 20 millimeters systolic and 10 millimeters diastolic. That's the maximum you achieved?
In simplicity study,
okay,
what is noted, an average follow-up which is noted is 20 mm systolic and 15 mm diastolic. In simplicity 2, it was about 24 and 15.
So that's the maximum achievable. The other query was, it's done bilaterally?
When you have the waist pressure starting itself is 160/100 is taken, then you can't expect it to fall more than that. Generally,
so for example, I have a patient where I've tried all drugs, and his BP is what, 220 by 160 diastolic.
Yeah, we do.
One of those rare cases where everything has failed.
In our second patient in which we projected, the initial targeted pressures were 200 by 120, and patients presented with LVF, NTG drips, and all were tried before. Especially this is seen in renal subgroup, renal failure type of patients where we have severe hypertensions, and this is found to be effective even in that subgroup of patients. Initially, because it's already not very well established, and we are using it for probably more sicker patients who have very severe hypertension. But probably as it gets more established, if you use it even for moderate elevated blood pressures also, it could work. But yeah, in that patient in which pressure was 200, the fall was about 40. The average fall, which was there in simplicity, what I projected was, because the baseline which they have taken itself is 160/100.
So the greater just one second, greater the blood pressure, the greater the fall.
Yeah, obviously.
Okay. The other was the procedure is done simultaneously on both sides.
Yeah, you are supposed to do it simultaneously, because again, if you do it unilaterally, the benefit may not be optimal.
And what was the time taken for the procedure?
It is actually less than about an hour's time. As you do it more and more cases, it could come down further. If you are doing in our indigenous method, probably you need to be more diligent monitoring and the catheter positioning, and again you need to be more careful. But RDN catheter, which is more thinner, 4 French, and it's all thing is prefixed. You just on the button, it does the job. Whereas in the indigenous method, you need to monitor it closely. That's why it could take a little more longer time. But it is very, I would like to again re-emphasize this point that it is not a procedure which can be done only by EP fellows. There's nothing, but for RF energy which we use, there's nothing that you need other information about electrophysiology or anything here. It is very easy to be done by any interventionalist or whoever can do a renal angiogram safely could also do this procedure safely, I feel, provided you use the monitoring energy delivery safely to it.
Finally, what is your follow-up?
We have the follow-up of about 6 months to 8 months now.
Thank you.
And one patient, there is again rise in blood pressure.
You see the BP fall immediately, or?
Yeah, we were seeing surprisingly, that's what I was mentioning. Probably the energy delivery which we are doing is little more compared to what was used by the RDN catheter. We are seeing significantly fall in pressures immediately on table, and then immediate post cath we were observing for 24 hours.
And there will be further fall over a period of time?
Then gradually it was stabilizing again. So it could be partly because also it produces some pain reaction when you're doing it. So that's why it is important to properly give them adequate sedation and pain relief with fentanyl and midazolam.
Well, Dr. Srinivas, what is the extent of denervation you want to achieve, and how will you know on the table you have done it? I mean, you want a 50% sympathetic denervation or 100% or 70%, and how will you know that it is optimal?
Actually, that is the point of debate and discussion which is going on basically, how to know that this procedure is done perfectly or not. You could just take the energy catheter there and come out, because it's not supposed to produce a relief of on table in 100% of patients. So as of now, it is being done empirically by taking it into all the sites, 6 lesions on one each side, and different directions, anterior, posterior, inferior, superior, and in modified ways it is being done. But you need to have a more definite answer which you can have on table. That would be better. But as of now, we don't have it. But we do see renal norepinephrine levels and total body norepinephrine levels, as well as when they studied later, other hormonal levels coming down, but that cannot be known immediately on table. I agree with your point. There should be a definite end point on table when to stop it. But in our patients, fortunately, there were significant falls in blood pressures which are happening. Then that's how we were stopping it. But it need not happen in all patients, I agree. We need to have more definite end point on table where to stop it. But as of now, it is only empirically delivering 6 lesions on both the side, both renal arteries in different directions.
And how frequently you will like to repeat the procedure? Once in 6 months, once in a year?
No. As of now, unless if patients are maintaining pressures longer, you don't repeat. Why do you need?
If you persist with the hypertension after your procedure?
No, that's again, we need to have more long-term data. That's what we are telling. As of now, we have data up to 3 years, which showed that there is no repetition is done in any patients. Whether again this is safer to do the procedure again is a point of discussion. We need to see the long-term follow-up.
Sorry for the interruption, Mr. Chairman. Ladies and gentlemen, that was leg 1 of this segment, renal artery interventions, what our fellows should know. We now move on to leg 2.
Thank you.